Good afternoon, everybody. Hey, there you go. Thank you. Thank you very much. For today's program, though, I want to thank our supporters. We have Genentech, Novartis, Sanofi, and TG Therapeutics, and I hope everybody could give them a round of applause and say thank you. Awesome. All right, so you saw in exhibiting today, we had Alexion, we had Genentech, Novartis, and TG Therapeutics. I want to thank them as well for being here, and so thank you for being here. All right, great. And I'm glad that you're all here. Let's get started. Where's Dr. Boster? He doesn't have a stage to come running in. He usually comes running in, jumps up on the stage, and screams out.
Howdy, hi. That was pretty darn good. Normally, when I start a chit chat and I say howdy, everyone just kind of stares at me. And you guys did a really, really good job. I'll give you like a B-. Let's try it again and go for a solid A. All right, really easy breezy. I'm going to say howdy, and you're going to make everyone on the internet turn their volume down a little bit when you're going to scream howdy back. You ready? Howdy. Howdy. I am so excited to be here today. I've been looking forward to this for months. And wow, you do not disappoint. I've traveled literally all around the globe educating families and doctors about how to beat up on MS. And I've never met a community like yours, ever, anywhere. It's amazing. You are amazing. And I'm just so impressed with this community. And the thing that strikes me is you seem to like each other and support each other. And that's a beautiful, beautiful thing. And unfortunately, that's not always normal in other parts of the world. So thank you for letting me see that. Stuart gave me a half an hour to chit chat with you before we start to answer your questions. And so I thought long and hard about what I was going to talk about. I even planned out a whole jibber jabber on the newest, latest, and greatest. And I don't want to talk about that. Instead, I want to talk about two things that are very dear to me. Number one, how do I conceptualize or think about treating MS? Like what do I actually do? And number two, more importantly, how do I help you understand that so that you can become a better self-advocate? That's what I really wanted to accomplish today. So I got a half an hour to do. I better get started. I decided to be an MS doc when I was 12. Now, I didn't know about neuroimmunology. I didn't know that I would be bald and 35 before I finished my training. I didn't know that I'd have to learn a whole bunch of new words that are real long, like too long for Scrabble. But I knew at 12 that nobody should make my grandmother and my mother that scared and that alone. My uncle was in the other room in his wheelchair. He was watching TV. He was fine. My grandmother and my mother, I walked in the kitchen and they were bawling. They couldn't get a hold of their doctor. And there was no internet. There was no National MS Society to help out. They didn't know what to do. So I promised my mother that I would learn to do it better. I had no clue what I was telling my mom at 12. I just knew that nobody should be that scared and alone. And so I've been a little bit mission driven. I was a weirdo in high school that said I'm going to be an MS doc when I grow up. And it was with great pride that I opened up my own center in Northern Columbus, my hometown, 2 days before the governor saw fit to close the state of Ohio, March of 2020. But it's been an awesome ride, and I'm very, very proud of my team back home. It makes me very desirous about helping people live their best life and learn how to make this disease boring. Because you can do that now, 2025. And so let's talk about how I think about treating MS and then how I need you to be my partner. All this jibber jabber about partnership deserves to be spoken about because it's not the way doctors are trained to think. So you have to help us think differently. Here's the dealio. We are a team, you and I. Right, we're a team. And I'm not actually in charge of the team. You are. See, here's the thing. I read books you didn't read. That does not make me smarter than you. It certainly doesn't make me better than you. It just means I read some stuff that you didn't read about. You are a you expert. You know more about you than any other person on earth. You know more about you than your children do, than your spouse does. You sure as hey know more about you than I do. Even with my fancy pants MRI and my MS Olympics and all that kind of, you still are a you expert. So we come together, you and I. We're a team. You bring the stuff that you know about, because you're real good about knowing about you, and I bring all the crap they made me read in med school. And then together we game out how to do this. Please think about this. I'm not a surgeon, which means I don't help you by cutting you open and removing an organ and sewing you back up and billing you. I help you by request. I ask you to do something. Would you please exercise as part of your lifestyle? Now, if I don't explain to you why I'm asking you to do that, you're not gonna. But here's the flip side. If I can help you understand why I need you to do that, you'll do my job for me. And that's what I want to do, is help you understand how I'm thinking about things and how you can help me be a better partner. So number one, the first thing that we need to think about when we're trying to figure out how to treat MS is, when do you need to call me? When do we need to chit chat? I mean, of course, we're going to see each other at our scheduled appointment, but when do you need to reach out? See, MS is weird. Some diseases are chronic, like diabetes is a chronic condition. And so you see your doctor at an interval, maybe every 3 months, maybe every 6 months. Other conditions are sudden, like a heart attack, God forbid. We got to treat that right now. MS is both. MS is a chronic condition, and it can have acute moments of uh-oh. So when do you need to reach out? Here's my rule. It's the 24-hour rule. I like that rule. When you leave today, I've got you thinking about your disease, and you're going to be thinking about your disease, and you're intelligent, and then your foot's going to itch, and you're going to ask a rational question. Is the itchy foot related to the disease? That's a rational question. And if you don't know about the 24-hour rule, it can drive you bonkers. So, oh my goodness gracious, I'm passing a lot of gases. Is my MS out of control? I don't know, because there's a symptom and I'm not sure if it's related to this chronic condition I have. When do I need to ask my doctor for help? 24 hours is the answer to that question. If you wake up and your hand's numb and tingly and you shake it out and it feels better, go start coffee. Start your day. You don't need to call me. If you wake up and your hand's numb and tingly, and then tomorrow it's more numb and tingly, now I need a phone call, because now it's gone on for more than 24 hours. Why? MS attacks are caused by inflammation. Inflammation doesn't go away in an hour or in a minute. If somebody got really mad at me and they chucked their water glass and it flew up here and cracked me right in my cheek, and my face got all swollen and puffy, tomorrow it's more puffy because it's inflamed, it's swollen up. When you had your first attack, God forbid, you lost vision in your eye, it wasn't for an hour, it was for weeks, months sometimes. So if you have a symptom lasting longer than a day, I don't want you to worry about that just yet. But if it goes on longer than a day, I want you to give me a holler. Now, the first thing I'm going to do when you call me is I'm going to assume you have an infection. Dr. Boster, you're a neurologist? No, I'm going to think that you have an infection. Here's why. If you've had MS damage on your brain and spinal cord, and then you get a urinary tract infection, upper respiratory tract infection, sinus infection, you raise your core body temperature 0.5 degree. It will short circuit those areas of damage. And all your old drama can come back out and revisit you. Now, you don't get an email that you have a urinary tract infection. You just know that you can't see out of your left eye again, and it's gone on for longer than a day. So if you want to play doctor in the bedroom, that's your business, but I don't want you to play Dr. Google. Right? Don't do that. Like, let us help you. Call me, say, hey, I'm having trouble with my vision again. It's gone on for longer than a day. And we're going to check and see if you have an infection. Now, I have a lot of patients that I take care of that don't live near me, so they can't bop by the clinic real quick. So we send them to their primary care doctor, which means they need a primary care doctor, right? And if you don't have a primary care doctor, then we have to go to an urgent care or somewhere where they can do a quick, hey, how are you? How are your lungs? Are you having an infection? And if we identify an infection, we give antibiotics, and it kills the bug and lowers your core body temperature, and the symptom goes away. That's a very real event, which happens all the time to my patients. It's not an attack. It's called a pseudo attack. It's a very real event. It really did happen, but it's not caused by new inflammation. It's short-circuiting old damage. And that's actually more common than an attack. But if you have a new symptom that lasts longer than a 24-hour period, and we can't find an infection, now I'm concerned that there's a different problem. Now I'm concerned that you're having an MS attack. exacerbation, relapse, flare. Oh, those are all the same thing. That's when something bad happens, and after a couple of days, you got to be honest with your wife that you can't see out of your left eye. What's happening when you have an attack? Let's take 10 seconds and level set what the hey MS is, all right? Because the problem with MS is a problem with your immune system. Your immune system's the part of your body that fights off foreign invaders. So when a kid coughs in your face and gives you a virus, your immune system identifies the virus as a bad guy and kills it. Now, I asked my stepbrother, who was a United States Marine, and he confirmed that you're not supposed to shoot your buddy on guard duty, right? He said, yeah, that's true, Aaron. No friendly fire. And we don't want the immune system to attack ourselves, but there are conditions where that happens. MS is one of them, where the immune system makes an error in judgment. And it thinks that a part of your body, in this case, the holiest of holies, the supercomputer, the brain, and the spinal cord, the superhighway that takes the information from the brain down to my boot and back up, gets attacked. Because when the immune system does its tour of duty and sees that part of your body, it thinks it's looking at a bad guy. And the way that it attacks it is with inflammation. And when that part of your brain or spinal cord swells up with inflammation, the nervous system doesn't work. It short circuits. So you have an attack or a symptom. And if we identify that you're having an attack and there's no infection, we're going to offer you steroids. Not bodybuilding steroids. No, we're talking about corticosteroids, right? And they can be given lots of different ways. We can do it IV. Pre-pandemic, I could typically send someone to your home. I practice in the great state of Ohio, and it's nearly impossible now to get a home health agency into your house to do that. But we have other ways to do it. We can take high-dose oral pills. We can do it that way. We can do a lot of different things, but the goal of all those different things is to hasten recovery and get you back in the game. Now, one more caveat. If you have an attack and you're on a drug to slow down your MS, guess what? That drug didn't work. Otherwise stated, if you're on birth control and you get pregnant, guess what? It didn't work. Now, are you going to stay on that birth control pill? Say, I got an extra child, but I'm sure it was just a fluke. No, you're probably going to change your birth control pill because that was not the plan, right? If you want to know why you're on birth control, go hang out with your 3 kids, right? We're not looking for an unplanned one. Does that make sense? So if you have an attack despite taking a disease-modifying therapy, a month later, we're going to sit down and have a very difficult conversation with that drug, which is going to sound something like this. Either A, you're going to tell them that you're going through some personal things and you need some space and that you're going to call them when you're ready, right? We're going to kick it to the curb and we're going to upgrade. Or we're going to put them on punishment. I tell someone, you bring my daughter home late one time, we're going to have a discussion about it. You do it twice, you're not going to see her anymore. All right, so either way, we're not just going to sit by and say, oh, well, that wasn't a very nice thing that happened. We're going to come back and reevaluate. So the first thing that I think about when I'm trying to help a family with MS is, when do you need to call me? Now, you may be sitting there saying, I'm not sure how to get a hold of my doctor at a random time. That's something you need to ask your clinician. Say, hey, doc, I understand that sometimes people with MS have attacks. If I have an attack on a Wednesday, what do you want me to do? And make sure they give you a real answer. Call in the office. If I call the office, will you see me? Can you guys see me within a day? You can't? Well, then what do you want me to do? Have that conversation with your doctor, right? Just so that you know what they expect and they know what you expect. That way you're on the same page. Remember, you're a team. The second thing that we need to do when we're trying to treat MS in patient-friendly language is treat things that suck. Right? We got to treat some stuff that sucks. When you have multiple sclerosis, you can accrue symptoms, which can erode your quality of life. And if I slow your disease down, which I'll get to in a second, and you're miserable, I didn't do my best job. And I don't do a bad job, not at this, no. In order to go home and look at my family and say, today I did a good job, I have to do 2 things, not 1, 2. I have to slow your disease down. I'll get to that in a second. But I also have to improve your quality of life. And the way that I like to improve your quality of life is by treating things that suck. Let me give you an off-color example. I don't think there's any children in the room. Anybody here munchkin? Good deal. So it's not a secret that we men are big fans of our erections. It's true. It's true. Let's be honest. And some gentlemen with MS can develop erectile dysfunction. If a gentleman I'm taking care of with MS has erectile dysfunction and that bothers him, I give him a little blue after dinner mint. If a gentleman with MS has erectile dysfunction and he doesn't care, I don't care. Because in this, excuse me, off-color example, treating erectile dysfunction doesn't slow the disease down, but woo, it makes Friday awesome. On a case-by-case basis, I need you to tell me things that suck. Because you look fantastic, sir. I have no idea that you're having a bladder urgency or a fatigue, which you can't explain to your spouse, or a burning pain in your hand that nobody will listen. I don't know any of that because, partner, you look great. So I need you to tell me things that suck. Let's break this down a little bit further. Whenever I talk to a family, I like to ask about the up theres. You know the up theres? Energy, mood, thinking, and memory. The up theres. Those are invisible symptoms which are very frequently impacted in the setting of MS, but we can't see it. So I like to ask about it. People impacted by MS are twice as likely to experience depression or anxiety compared to the general population. But that's treatable. I can treat that. If you're so fatigued that you can't get through your workday and you're getting written up, that's not okay. We have to do something about that. If you can barely get through your workday and then you have to sleep when you get home and you have no quality life and you can't spend time with your family, we're not doing adequately. And if you're having trouble thinking and it's interrupting your ability to earn your daily bread or to interact with your loved ones, that's not okay. So if you're having trouble with the up theres, I need you to tell me about it. And there's a bunch of stuff that we can do to treat the up theres. Pick one of those three problems. Thinking and memory, energy, or mood. First one shouted out, energy, she said. Now pick a number 1 through 8. 8. Let's come up with 8 things that improve energy in MS. Fair? All right. Somebody keep track because I can't count to 8 when I'm up here talking to you. Number 1, I need you to get good sleep. Now, that sounds like something your mom told you because she did, and guess what? Mom was right. Getting restorative sleep is critically important. Most of us don't. I need you to budget for at least 7 hours of snooze. If you're watching the Late Late Show, getting in bed at 1 and waking up at 6, you ain't budgeting for 7 hours of snooze. And if you're not getting restorative sleep, you're literally cutting your legs off before you start your next day. You're making life real, real hard on you. And so if you have to get up 4 times a night to go pee-pee, if you have spasms that wake you up from sleep, if you can't fall asleep because restless legs driving you bonkers, if you snore and wake yourself up because of sleep apnea, we have work to do if we're going to try to improve the up theres, if we're going to help your energy, because we have to address sleep. That's number 1. Number 2, you need to exercise as part of your lifestyle. Wah, wah. Really, Aaron? Yeah, really. The data is profoundly clear. If you don't exercise as part of your lifestyle, you'll end up more disabled. Very clear cut, right? Now, we can't exercise the way we did in high school. I can't exercise the way I did in high school. I can, this is a true story. I used to be a competitive weightlifter. I can't do my warm-up anymore. I'm 50. I can no longer do the warm-up that I used to do to get ready to work out. But I do about half the warm-up, and that's all I can do for the next 3 days. But I do it, right? And so we have to be adaptive. But if you want to improve your energy, exercise a couple times a week. You'll be shocked at what happens. It's really weird. Number 3, we got to eat smart. That involves avoiding sugar. Wah, wah. If you're tired, you want to do a weird experiment, remove sugar out of your diet for about a month, and then you can message me, and you'll be like, woo-wee. Every time someone does that, they're shocked, and it's joyful when I watch it happen. When you remove sugar from your diet, your energy spikes. It's really, really weird. What number am I on? 3. So I told you I couldn't count. Number 4 is we have to treat depression. If you're sad, blue, and depressed, it'll drive your energy down lower. If we treat the mood, it makes the energy better. Think about that. You might not care that you're irritable, even though your family does, but you may care about your energy level. And so if we give you a pill to help with that, it can help with that. Because when you think about the up theres, energy, mood, thinking, and memory, if one goes up, it pulls the other 2 up. If one goes down, it pulls the other 2 down. So we got to work on that. What else do we need to do? We need to look at the medicines you're on to make sure that we're not contributing to the problem. I gave you that bladder medicine 5 years ago. Makes you tired. Side effect of a bladder medicine. I gave you that baclofen to help you with your spasticity. You're welcome. Makes you tired. I gave you that Lyrica because you had burning legs. Makes you tired. So we have to look critically at your medicines. And I recommend that if I want to put you on a medicine, you say, okay, which one are you going to remove? Right? I don't want to go up in the number of pills. So if you're going to add one, doc, can we remove one? That's the exchange program that we have, right? Because we don't want to be on 100 million medications. I don't want to prescribe them. You don't want to take them. What number is that? Number 5. Okay, here we go. Taking a disease-modifying therapy actually improves energy. Now, doctors don't talk about that enough, but when you look at the clinical trials data, the group that was on the drug, their energy scores are way, way, way better than the ones that weren't. And so I don't want us to forget that because that's actually very, very important. What else can we do to help with energy? There's medicines for energy. There are medicines that trick your brain into being more awake. And they can make the difference between I can't function, I can't provide for my family, I can't spend quality time with loved ones because I can't keep my eyes open, to changing that dramatically. There's a gentleman I take care of back in Columbus, and he's a partner in a law firm. And the other partners were going to vote him off the island. They were going to fire him because he couldn't stay awake at work. So I gave him one of these little pills. He hasn't had a problem the last 9 years, crushing it all day. And so those medicines can be very, very impactful in trying to figure out a way to improve the up theres. I'm going to not do the last one because at this rate, Stuart's going to make me stop talking in a few minutes. And I want to talk about the down theres. You know the down theres? Yeah, the down theres, bowel, bladder, bedroom. The down theres are invisible symptoms which are very common in MS. And in polite culture, we don't talk about it. But guess what? With your doctor, the partner that you have to help you make this boring, the partner that you have to remove things that suck, we have to talk about the down theres. So bowel, bladder, and bedroom, we got to discuss those. And if you're having trouble with it, that's not okay with me. I have people that have stopped attending church because they don't want to wet their pants in church. And that's terrible for multiple reasons. I can help them attend church without fear. They can get through the sermon and they won't wet themselves, right? So let's pick a problem, bowel, bladder, or bedroom. First one. Bowel, I heard first. Okay, now you know, now you're going to pick a number 1 through 10. 5, the guy figured it out. He's like, if I pick a big number, he's going to talk too long. Thank you, partner. So let's talk about bowels. The most common problem that I see with bowels is constipation. A lot of people with MS, they don't poop very often. They don't talk about it, but it's like an act of Congress to have a bowel movement sometimes. The other problem that I see with MS is something that's like irritable bowel syndrome, where they'll go from extremes to where they're having trouble pooping and then they have a couple days where they don't want to leave the room, right? And so, but what's common is normally bowels are not normal with my patients. That's what I've experienced for the last 20 years. And so there's things that we can do about it. Number 1, we can make sure that you take a probiotic. You know, ever heard of a probiotic? So our gut are lined with bacteria, like trillions of bacteria, and they help us process our food. They're supposed to be there. And there's something really weird. People with MS have abnormal gut bacteria. We don't know why, but they do. So if we sample your gut bacteria, it ain't normal. Probiotics is a capsule with billions of healthy gut bacteria, which is weird, but just swallow it. And it goes in your gut and it repopulates your gut with better gut bacteria. Now, there's actually some really weird science that suggests that could maybe help with MS, but that is not why I'm talking about it right now. It makes the good bacteria help you digest your food better. And it makes a really, really big deal. Now, the bacteria in your gut, they don't eat steak, they eat fiber. Fiber is an indigestible solid like sawdust. So if you eat sawdust, it's coming out there because you can't digest it, but the bacteria can. And American diets don't have a lot of fiber in it. Fast food removes fiber because it makes it cook faster, but we need fiber in our diets and we need to feed the microbiome. And fiber is like a sponge. So you add a sponge plus water plus stool, you make it big and bulky, easy to hold on to, easy to get rid of. That's what we're looking for. So probiotics and fiber, very, very valuable. Remember the exercise thing I was talking about? Getting up and going for a walk, doing your exercises, moving around, helps get your gut stimulated. We saw it all the time in the hospital. Someone comes in the hospital and we keep them in a bed and they don't poop. That's because they have a routine, or they drink their prune juice and they go for a walk around the block. Movement can help you move your bowels. What else can we do to help with bowels? We can stimulate a bowel movement. We're all adults, enjoy your lunch. So if it's been 3 days and you haven't gone, we need to inform the bowels that we're done playing around and it's now time to have a BM. So how do we do that? Well, one thing I like to do is digital rectal stimulation. Oh, geez, she says. Now, hold on. Nobody's going to be there with you. You're all by yourself. You can wash your hand when you're done. So you put the finger in the rectum, move in a circle. There's thousands of nerve fibers that go straight up to your spinal cord, say, hey, psst, hey, it's time. And it allows you to have a bowel movement. And it's free because you got 10 digital rectal opportunities, all right? My point is, if you're having trouble moving your bowels, that will help you move your bowels. It's very, very helpful, okay? And the last thing, number 5, I think this is 5, is taking advantage of the best time to poop. You know there's a better time to poop than others? Your bowels try to empty 15 minutes after your first warm beverage in the morning. You drink that warm beverage and it hits your stomach, and there's something called the gastrocolic reflex about 15, 20 minutes later. Now with MS, you may not be informed that your bowel's trying to move because the spinal cord's no longer alerting you, but it's happening. So go sit on the john. That's your best opportunity to have bowel movement. All right, that's 5 things to help with the down theres. Now, when I'm trying to help you with your MS, and I'm also trying to help you be a self-advocate, you have to tell me about that. Because if I say, hey, is everything okay? And you say, uh-huh. Okay, great. Want to see vacation pictures? Like, what are we going to talk about? This partnership is intimate. It's an intimate relationship. Not intimate like we hold hands and smooch, but intimate like we have to game out the real deal Holyfield, how we're going to help you live your very, very best life. So you have to tell me that you can't poop, or that you can't achieve orgasm, or that nobody wants to be around you because you're really irritable. I need you to, when I say, how are you doing? I'm not being Midwestern polite. I need to know how you're doing. And when a patient says, fine, I say, bullshit. Or I say, is that a polite fine, or are you really doing grand? So I need you to tell me about that. Then we can game out what to do. And I tell my patients, you're going to list a problem, and I'm going to get all animated. I'm going to go, ooh, and I'll list all these things we can do. And then you'll say, no, never, you're a weirdo. I can't believe you said that in front of my husband. Maybe, yes. And we're going to custom tailor what we do to try to help improve your quality of life. So I need you to know when to call me. Attack, pseudo attack. I need you to tell me about things that suck so I can help you make it better. And lastly, I want to do some things to slow the disease down. How much time do I have? Oh, good. All right. So let's talk about how we try to slow the disease down. I have this dumb saying that I want you to be 5 for 5 in your fight against MS, because that rhymes. And so I want to just go through all 5. And I want to point something out. 4 of the 5 I can't do. You have to do. I can't do them for you. I can teach you about them. I can encourage you to do them. I can give you tricks and tips to do them, but I can't do them for you. The 5th one is a partnership. So let's go through all 5. Number 1, exercise is part of your lifestyle. We talked about that a second ago. And that's mean. It's a mean thing to say to someone who has trouble walking. Oh, go exercise. Well, thanks, doc. I would love to go exercise. It's not easy to exercise with MS, but we have to figure out ways to do it. All right, and let me give you some tips. Water is magic. In the water, you weigh less. So that weak leg that cannot support your weight on land can support your weight in water. Spasticity, which plagues many of my patients, particularly right now when it's cold outside, dissolves in the water. If you're having a bad day and you keep leaning to the left, the water keeps pushing back to the right. You can't get overheated in the water because it wicks the heat away from your body. So my patients can achieve things in the water that they can't necessarily achieve on land. Water's magic. The second tip that I'll share with you as it relates to exercising as part of your lifestyle is the value of a physical therapist. Many of us remember the glory days of high school, right? And that's the last time that we really exercised with any vigor. And that's kind of all we know how to do, which doesn't work real well when you're an adult. Remember me trying to do my warm-up? It's also really, really hard in the setting of MS because now you have other words to contend with, like I'm unsteady on my feet, I have ataxia, I have spasticity, I have motor fatigue. A physical therapist, particularly a neurophysical therapist, is a trained expert on how to beat that. And so if you're not sure how to get started in exercise, there's no shame in that game. Ask to go see a physical therapist. They'll do an assessment. They will whoop your tushy. They are some of the nicest sadists I've ever met. They're lovely people. Oh, you're doing so great. Let's just do 28 more. Ah! So using a physical therapist to get you going is what I want you to do. And what you do is you tell the doc, send me to a PT and write home wellness program. Help them develop a program to do when you graduate. And that's a great way to get started. That way you're not trying to power lift the way you did when you were a little kid and hurting your back. And oh, that's me. Sorry. So exercising is part of your lifestyle, something I need you to do. Number 2, I need you to eat smart. I hate when doctors say dumb stuff like, it doesn't matter what you eat. I hate that because it's false. It does matter what you eat. I talked a little bit ago about sugar. There's a lot of things that we can do to slow down MS and to improve symptoms by changing what we eat, right? It takes a lot of work. And we're going to start off easy breezy cover girl right now. Not going to get very hard today. One thing that I want you to do is I want you to up your water game, all right? Many of us are up your water game. Drink more agua. We need to increase your water. I want 86 to 100 ounces of water a day, guys. That's a lot of water. Now check with your doctor, make sure I'm not crazy, but I'm not, I don't think. And increasing water intake does a major renovation to many MS symptoms. Spasticity improves when you're hydrated. So does depression, interestingly. So upping your water game is very important. Now, many of you are sitting there going, no, you don't understand. I'll wet myself. I'll have to get up to go to the bathroom all the time. I want you to get up because I got you to exercise, right? So what we're going to do is we're going to drink 2/3 of all the water you're going to drink in the first half of your day, which means you are a rock star water drinker from the moment you get up all the way past lunch. Then you're going to back off, and by dinner, you stop drinking water. After dinner, no more water. Now, don't walk around your house going, but if you do a good job of drinking water in the morning, you're not going to be thirsty in the afternoon, and therefore, you're not going to be bringing water to the bedside table. When you drink water, how long do you make urine afterwards? 6 hours. So if you drink water at 10 p.m., 11, 12, 1, 2, 3, 4 a.m., you're going to pee all night long. All right, so we need to increase the water intake, but we've got to change how we do it. The second thing is we need to supplement vitamin D. So vitamin D is really weird. We get it through an interaction in the sun, and we're taught, don't ever go out in the sun. God forbid, that would be terrible. And so a lot of Americans' vitamin D is very low. Here's the weird thing. Raising vitamin D slows the disease down. That's weird, but true. And so I want your vitamin D level to be higher. Now, there's 3 ways to get vitamin D. You can go out naked in your backyard, full sun, 15 minutes. You will absorb on a full sunny day 5,000 international units of D3, which is what I want you to take. But you may get frostbite on personal private parts, and you may end up with pictures on the interwebs. So I need you to be cautious if that's how you choose to do it. A second way is you could eat a salmon every day. Not a piece of salmon, a whole salmon, right? Because I need 5,000 international units, and a dinner portion of salmon is 500, so you got to do 10 of those. So you can just eat 1 salmon every single day, and you'll be fine. Now, if you don't like those options, I got a third option for you. You can take a pill, right? And you can take a pill. I like people to take D3 because it's better absorbed in the human body, and we're trying to push that level up, right? So eating smart is very important. Now, it gets more complex after that, but I'll just give you a little teaser. Eat real food. If you're eating something and you look at the ingredients and it has words that you can't pronounce, that's not a food. That's a chemical. I don't want you to eat that. You learned all the food words when you were like 5. Broccoli, chicken, that's food. Apple, that's food. That's not a food. That's a chemical. I don't want you to eat that. So if you're trying to figure out how to eat smart, up your water gain, take some vitamin D, and then just, if the words are not pronounceable, don't eat that. Eat something different. I like food that has words like ingredients, apple. That's what's in there. Or lettuce. Like, those are all the ingredients. All right. So you want to eat smart. What else can we do? Show of hands if you've heard of mindfulness. Some of you have heard of, oh, good, excellent. Mindfulness is the act of being in the present moment without prejudice. So I joke, if you're having sex and thinking about work, you're doing it wrong. That's not right. You're not doing it correct. You need to be in the moment, thinking about the moment, not worrying about what happened yesterday or what's going to happen later. You lose yourself. Kids are real good at this. Adults, not so much. Why do I want you to practice mindfulness once a day, every day? Because stress makes MS worse. That stinks because life is stressful. Husbands are stressful, let's be honest, right? Like having a mortgage is living life is stressful. Good stress, like getting married, going on a vacation, that's still stressful. And stress makes MS worse. So I need us to learn to manage stress. I hate when doctors say dumb stuff like, remove the stress, honey. Okay. Did I do good? But learning to manage stress is really important. I have a lifestyle of showering every morning. You're welcome. And when I finish my shower, I sit on the floor of my shower, cross-legged, water running, and I go through a breathing exercise. I started doing that during the pandemic because I got so anxious getting ready to go to work in the morning. That helped calm me down, and I still do it today. Every morning I do that. Now, you don't need to sit in the shower like a weirdo like me, but I want you to do something 5-10 minutes every single day. You can have a mindful meal if you just turn off all the peripherals and take a moment to appreciate who you get to sit with and eat with. Take a moment and taste the food. There's lots of things you can do to be mindful, right? The next one, number 4, is to not smoke stuff. Oh no, crap, what's he gonna talk about? So lighting carbon-based stuff on fire, and then sucking in the smoke is pro-inflammatory. It can actually speed up your MS by about 50%. So that's a really big deal. So if you want to smoke, you're welcome to. You're an adult, you can do anything you want. But and it's not my job to make you not smoke. You're an adult. But it's my job to educate you about what that does and then to shut up and let you tell me what you want to do. So if you smoke cigarettes, I'm allowed to say, how's it going? And you say, I'm smoking fantastic, thank you. And I'll tell you, if there's a point in time when you want help quitting, I will help you. Now let's talk about cannabis. Anybody ever heard of cannabis? Some of you, not really? Okay, well, so cannabinoids, when I was a kid, we used to call that weed, help a lot of my patients with symptoms, a lot. But I don't want you to light it on fire and smoke it, given the option. I would rather you consume it in a different manner because lighting the carbon-based thing on fire and sucking in the smoke, that can speed up your disease, and that's not our goal. Fair? Now, the last thing is to take the most effective disease-modifying therapy that you're comfortable taking and make sure it's working. So let's talk about that. If we want to live our best life despite having MS, I want to bring everything I know how to bring to bear. I want to help you learn to exercise as part of your lifestyle. I want to teach you how to eat smart. I want to teach you about mindfulness. I want to teach you about brain health and not smoking. And I want to make sure that we're on a medicine which is going to slow your disease down. Because in the modern era, it's a great way to help make this boring. Now, there's a bunch of different MS medicines out there, which is wonderful. When I started in this field, there were 2. Now there's 28. That's fantastic. At my center, we're working on many, many more. Very exciting time. And I'm not standing up here because I want you to take drug A or drug B, but I want to make sure that you're on a drug and I want to make sure that you're responding to that drug. So how do we identify if you're responding to your drug? Well, in some cases, it's really easy, like with birth control pills. I can tell you whether you're responding or not. Just let me see a family picture, right? But other things are not so easy. Like MS is not so easy. So how do we know if you're responding? I want to keep you on your medicine, your disease-modifying therapy, unless there are 1 of 5 things going on. So what are the 5 things? Number 1, if you have an attack on your drug, I'm not okay with that. Because the reason we take the drugs is to not have attacks. Now, does that mean that every single time you have an attack, you have to change? No, but it means we have to talk about it every single time. I'll give you an example. A gal that I take care of in this state, and I'm seeing her with her husband, and she had an attack, and we had to treat it. And I said, we have to make a decision if we're going to cut bait right now and upgrade or put it on warning. And she goes, let's put it on warning. And her husband said, that's what you said last year, honey. We upgraded. Got to have that conversation. It's really, really important. What was I just talking about? I just blanked. That's funny. Thank you very much. Woo-wee. So, and I've only had coffee this morning to drink. So attack. The second thing is a new spot. We can take a picture of your brain and your spinal cord. We can take a picture of structure. And I don't want to see any new structural damage. We already have structural damage. We know that because that's how we diagnosed you. I don't want to see any new damage. There is a crack in the foundation of my basement in my house. My house is old, right? And ever since I bought the house, it has a little crack in it. There's never been any water. There's no new crack. It's not bulging. I'm not worried about it. But I check it every time I go downstairs. And as long as the crack doesn't extend, I'm not going to do anything about it. Once a year, I want to take a picture of the holiest of holies, the supercomputer that runs your entire body. And I want to make sure that I don't see any new damage. If I see new damage, something ain't right, because the drug I'm giving you is intended to prevent that from happening. So if that's happening, to me, it means the same thing as an attack. So no new spots, or we're going to have to talk about maybe doing something different. Number 3 is you're getting worse on your exam. Let's talk about progression. There are two ways that you can get worse in MS, like develop problems in MS. One way is you have an attack and you don't recover all the way. So let's say, God forbid, that you have an attack in your left leg so weak you can't walk, and then it heals, but it doesn't heal 100%. So now you have a hitch in your giddy up, you have a limp. You've accrued a degree of disability because you didn't fully recover. That's one way that you can get worse in MS. It's actually not the most common way. It's not the most common way. The more common way is something that we call PIRA. We're nerds, we make up things, we make up terms. PIRA, progression independent from relapse activity. That's where you get worse independent from an attack. Both can happen. And we have to call it out when it occurs. That's another thing the doctor can't see. I haven't seen you in a couple months. I don't know that you're having increasing difficulty walking from your office to your car. I don't know that. I don't know that you've stopped going to see your son play soccer because walking across the grass is becoming increasingly difficult. You can't do it. I don't know that you stopped playing mahjong with your girlfriends because you're getting confused and they're teasing you, and so you don't want to do that. I need you to tell me when something ain't right? Because we're developing drugs which increasingly are able to thwart all kinds of aspects of MS, including progression. So you got to tell me about that. I'm absolutely honored that I got to meet this community. So thank you to the organizers. Thank you to MS Views and News and Stuart for bringing me down here. And thank you to all the sponsors. I wanted to try to do two things today. I wanted to share with you how I think about treating MS. When do you need to reach out? Are we having an attack or a pseudo attack? I wanted to talk about treating things that suck, treating chronic symptoms so we can improve your quality of life. And then I wanted to talk to you about how to slow the disease down, being 5 for 5. Exercising as part of your lifestyle, eating smart, not smoking stuff, mindfulness, taking a medicine, make sure it's working. But more important than that, I wanted to ask you to be the best self-advocate that you can be. I wish every person with MS could see a fellowship-trained, board-certified neuroimmunologist at a comprehensive multiple sclerosis center. Do you know what percentage of American MS patients do that? 20%. Because there's not a lot of us, which means that 80% of people impacted by MS are not necessarily going to see an MS Center of Excellence, which is why I need you to be a really good self-advocate, because you're a you expert. You know all about you. And so you need to talk to your doctor. If you talk to your doctor and say, hey, I got this problem, man, this thing sucks. And the neurologist says, well, that's not my area of specialty. Say, doctor, it's okay if you're scared to treat it. You're allowed to be scared. Don't say that. I'm teasing. You can say, doctor, that's okay that you don't want to treat it, but would you do me a favor and send me to someone who will? Because I don't like the fact that I wet my pants, and I would like some help in not wetting my pants. So if you can't do that, do you have a colleague that can help me, please? That's annoying. Let's be honest. You don't want to medicalize your life and see 100 different people, but I don't want you to pee your pants and not go to church. So you need to be a self-advocate, right? It doesn't affect the doctor. He's not bothered by you peeing your pants. He doesn't get wet. You do, right? So you need to remember that it's your body. It's your brain. It's your insurance money. You're a you expert. Thank you for your attention.
Thank you very much. I got to give kudos to Suzanne, who asked me to ask Dr. Boster to be here today. So let's give her a round of applause. Fabulous. Anybody have questions? Raise your hand. You're going to ask a question. Raise your hand. Let me acknowledge that I see you, that I'll get to you. We have online questions. We have a list of people who sent in questions previously, and we're going to take questions from the back of the room because they want to see me run around here today, right? I need my exercise.
Nice.
All right. Somebody wants to, she's like a ventriloquist. She gave it to me. She's going to move her lips, though, while I say it, all right? Is there any connection between MS and pancreatitis?
No. So there isn't a connection that we're aware of.
When talking about vitamin D levels, like when you have your blood work, what should it be? Because mine hovers near high, but it concerns my doctors and they take me off
So let's talk about that.
So-
So here's the medical caveat. Like, I can't give you advice for you, and you have to ask your doctor what's right for you. And I'm just educating you. Don't sue me, blah, blah, blah. Right. Okay. So now I can answer your question. So the lab test that I like to check in my patients is a lab test called the vitamin D 25OH level. That's the lab. So that's the lab I send off. And it's not a terribly expensive lab. You can do it at Quest or, LabCorp or what have you. And it comes back in solid numbers, right? And so the American FDA says that anything above 30 is good for you. But in the setting of MS, I want it above 50, right? So the magic number for Aaron is 50. And I don't want it above 100. So I'm looking for that to be between 50 and 100. And if it's over 100, then I hold the vitamin D and I let it drift back down. And if it's below 50, I ask you to take some more or go outside naked.
Great.
I wanted to know about remyelinating.
Amen. My sister from another mister. So one of the biggest problems with MS, like from a pathology standpoint, from what's actually happening in the brain, is that the plastic coating on the wire is being stripped bare. So if I went to your stereo and I stripped all the wires bare, there would be a high likelihood that they wouldn't work very well and that the wires could actually break. And that's what happens in your brain when MS demyelinates. The myelin is the plastic coating on the wires of the brain. So what we do presently when we're trying to treat MS is we try to stop the immune system from doing that. We try to get it to knock it off. But that doesn't give you back the stuff that got stripped away. So it would be pretty slick if you could put the plastic coating back on the wires. That's called remyelination. Our brains remyelinate, not on command, but our brains are capable of remyelinating. So what some really, really smart scientists are trying to do is to figure out how to turn that back on. Not rando, but like specifically to help remyelinate. And we have been trying and failing again and again. So pipe 307 just failed. And that's a real bummer because we were really excited about that. But we're not done yet. Now, if you don't know me, I'll tell you that I don't know anything about sports. So when I make this next quote, it's particularly funny because I don't know who Yogi Berra is, but I think he was like a coach. And he said, if I keep banging on the door one day, I'll break it down. And that's the way I feel about remyelination. I'm going to share with you a study that we're starting up at my center. Very exciting. This is a study looking at people with MS who are stable on a medicine. So we're only enrolling people not that are having events, but are not having events. And we're going to implant a device in their neck called a vagal nerve stimulator. And that vagal nerve stimulator has the ability, when you turn it on, to stimulate the brain. It's used right now for treating seizure disorders. But there's a theory that we might be able to stimulate the brain to remyelinate. So in this trial, people are going to get this gizmo in their neck, and we're going to turn half of them on and not turn half of them on, and they won't know which ones are on. I actually won't know which ones are on. And a year later, we're going to turn all the rest of them on. And we're going to look for 2 years and see if we can grow myelin, which is pretty neat. So it's a brave, brave new world. We're not there yet, but again, just like that coach said, we're going to keep trying.
Is there a connection between Chiari malformation and MS?
No, but as my mentor used to like to say, sometimes nature's too generous. And you can have a Chiari malformation, which is a problem with the way the back of your skull formed, and you can have an autoimmune disease. Sometimes nature's too generous.
Any over here? All right, one that came in online before I start making my way around the room. Person is 73 years old. They were taken off of their medication by their doctor because he doesn't like keeping people on medications after they turn 65. She wants to know, of course, what you already know, and you can tell everybody what they should be doing.
So you know how there's like fads? Like there was a fad when I was in high school to like pop your collar up and like to like duck your jeans. We would duck our jeans. That was a fad. People don't do that anymore. That's a fad. There's a fad in MS neurology right now, which drives me bonkers. It's called ageism, where people say, oh, well, congratulations, you celebrated your fill-in-the-blank birthday. Let's take you off your medicine. So I don't like that very much, right? Why? Well, first of all, why are they doing that? Because doctors are not completely like goofy, like they think they have a reason, right? So it's true that as you age, your immune system slows down. That's true. Your immune system is not as active in your 70s as it is in your 20s. That's true. And it's true that the impact of the medicines that we use seem to work better when you're chronologically younger than older. That's true. But what's not true is therefore you should take someone off their medicine because they had a birthday. I'll share a study with you where they took a bunch of people that were 55, which is not old, and they had had no disease activity for 5 years. That was the rule. Like, so no attacks, no nothing for 5 years. And they took them off their medicine. And then they watched them for a couple years. And they concluded that it is safe to take people off their medicine because only 1/3 of the people that were taken off their medicines progressed in disability. Excuse me? If that's my mother, we're going to have a little difficult conversation because it's not acceptable to me. If you take my mom off her drug and she gets worse because I could have left her on it, she was doing fine, thank you. So here's when I like to stop medicines. I've been practicing MS for 2 decades, and I've always been very consistent. I always stop drug at death. I've never ever treated someone after death, not once. I've given 0 dead people a disease-modifying therapy. The medicines are not tested in dead people. The medicines use your circulation to move the drugs around, so that I don't even think they would work. So that's when I always stop them. Pre-death, we have to simply answer a question. Do you have any neurological features that you like having an orgasm or seeing or moving your thumb? Like, do you like any of those? If you like any of those neurological things, why don't we do something to preserve the neurologic reserve and protect your nervous system against attack? Now, is it appropriate to consider the risk benefit? Always. And as you age, risks can go up. That's true. So as you age, you can have an increased risk of an infection. That doesn't mean that we shouldn't treat you. It just means that we have to constantly weigh that risk benefit. Are there people with MS that I take care of where we've stopped their medicine? Yes. Because the medicine was making them worse because of recurrent infections, then I was helping their MS. But that's not because they had a birthday. That's a unique individual situation for that family. So I apologize for the passion of my voice, but I think it's nonsensical. And if the doctor says, hey, I think we should take you off, say no problem, but I don't. And it's my brain, doc. So if you're wrong, I pay the price. I choose not to do that. So with respect.
Thank you. Next question.
Are there any measures that we can take to encourage remyelination? Anything that we can do?
I have to cheat answering your question because I don't know how to do that. All right, but I'm going to cheat a little bit. I'm going to pivot and hope that you don't notice. There are things that we can do to preserve brain volume. So brain volume is slightly different than remyelination, but brain volume, shrinking brains is bad for MS. People impacted by MS can have their brain shrink faster than we would like upwards of 10 times faster untreated, and that correlates with disability. So there are things we can do to slow down brain volume loss. So I'm cheating, I apologize, because I don't know how to do the remyelination yet. But taking vitamin D and not smoking, taking a disease-modifying therapy, exercising a part of your lifestyle, all those things have been shown time and time again to maintain brain volume, which I think is super important. And I hope one day that I can actually genuinely answer your question because I hope I'll know the answer.
You have a bunch of things on the internet like ivermectin that I used to give my horse for worms.
I'm told that it's an outstanding deworming drug for horses.
It works great.
So I'm sorry, the question is about.
But people are thinking you see it cure different things, and people are out there grasping for straws.
So let's talk about that for a second. If you go somewhere in public and say that you have MS, something very interesting happens. Suddenly, people are geniuses and they're going to tell you how to fix it. Have you tried yoga? Right? Well, if you juice celery every morning, okay. So, and I think people probably are coming from a good position. They want to be helpful. I don't know, but sometimes we just have to smile and say, "Oh, thank you, and God bless you, bless your heart." In the North, we know that when you say "bless your heart," we know what that actually means. So I think we have to take cures with a grain of salt. I do not prescribe ivermectin because I'm not a veterinarian. and I wasn't taught about ivermectin in med school. I checked. And I hear all kinds of things, but you're not an experiment to me. And I love it when my patients bring me, hey, what about this? What about that? I love that. I need them to do that. But I'm also going to be real honest and say that scares the hell out of me. I don't want to do that. We have to have, again, it's an intimate conversation. Here are my 3 rules for taking a medicine or a complementary therapy, something I wasn't taught about in med school. Like ivermectin for horses, I was not taught about in med school. So 3 rules. Number 1 rule is it can't be too expensive. Whatever that thing is, it can't be too expensive. And only you know whether or not something is too expensive for your family. Number 2, it can't be dangerous. I would submit to you that ivermectin actually has risk. And just because something's natural doesn't mean it's not dangerous. Arsenic is natural. Cyanide is natural. Belladonna is natural. Right? Bears are natural. So just because so we have to ask, is it dangerous? And the third thing is, I don't want it to be instead of something that I know works. So if you tell me that you're going to take low-dose naltrexone along with your disease-modifying therapy, I'll prescribe it for you. But if you say that you want to do it instead of your disease-modifying therapy, now I'm very nervous that we might not win. Thank you for that question.
I'm going to be greedy, and I have 3 questions.
Okay, hit me.
One, when you talk about restorative,
Can you do the questions with Roman numerals like question
Sure.
I?
question I,
Question I.
is it deep sleep restorative sleep?
Yes.
So okay, that was 1.
Yeah.
2.
So the question just was, when I talked about like deep sleep, did I mean restorative sleep? And that is what I mean. Yes.
Okay.
Yep.
So 2I.
I.
I know it was a small study, but there was a study done. It doesn't matter exactly. A American university
Okay.
that talked about GLP-1 being very helpful for MS, and they think because it reduced inflammation. What are your thoughts on that? And
Wait, don't do I because then I'll
Okay.
forget. And then I'll be like, well, what was I? So let's talk about I before we talk about I. Yeah, I really did that. So GLP-1s, all right? So GLP-1s are a class of medicine, all right? And it's a class of medicine which was invented to help diabetes, which is an autoimmune disease, but it also helps weight loss. And it's helped a lot of Americans lose a whole bunch of weight, right? And so they're being used a lot by lots of different people, not just people with diabetes, right? And the research that's come out that I've looked at makes me feel comfortable that it's not dangerous in MS. So that was one of the questions I had, is like, is it going to be dangerous for my patient? And I don't think GLP-1s are dangerous for patients, for my patients. The second thing is, being overweight is actually a problem in MS. It can create a problem for you, right? Because if you have a weak leg and you're carrying extra weight, that's extra weight on that weak leg. That's actually a major issue. If you lose the weight, your leg's not stronger, but you can walk better, right? So managing weight is important in MS, and yet that's like an evil trick because it's hard to exercise in MS. And so previously, if a patient of mine needed to lose 100 pounds or more, my only viable real option was a surgery, like a gastric bypass or a sleeve, which is very effective. But now I can use a GLP-1 instead, which I love. Now, that was not the question. The question was, question I was, could it help MS? And the answer is we don't know, but it looks like it might, because it's creating this like autophagy state and cleaning up cellular debris. And so it might actually help. We don't know that yet. Now, I'm going to tell you something a little weird. This part's not weird. I have a friend. That's not weird. His name's Darren Akuta. He runs UT Southwestern. He's one of the smartest MS neurologists on the planet. He's a neat guy. And he early on went to one of the manufacturers of the GLP-1 and said, I want to do a clinical trial on MS. And they said, no, thank you. So we don't need to do that. We're making enough money without that indication, which hurt my feelings.
Okay. So if you have what they're now calling smoldering MS,
Dun, dun, dun.
and your scans are showing that you're stable as far as lesions, but you are getting worse, does that qualify to change your medication?
I think it qualifies to have a conversation about it. I think that's kind of where we are right now. But let's address that, because there's something called medical gaslighting, which goes like this. Oh, Congratulations, honey. You look fantastic. Yeah, but I'm getting written up at work. Yeah, but you haven't had any attacks. You're doing great. Yeah, but I fell and I broke my arm. Yeah, but your scans are stable. You're doing fine. Why am I getting lost trying to find my car? That is a real conversation where the person is desperately trying to get their doctor to understand that they're failing a litmus test of life, and the doctor is celebrating because their scans are stable. Both are true. Both are true. We're allowed to celebrate that your scans are stable. I don't want you to have more brain damage. We have enough already. So if we have new scans that show no new brain damage, we're allowed to be very happy about that. That's a good thing. You're taking the medicine and working really hard to accomplish that goal. Good job. If you haven't had any attacks, that's a good thing. That's a wonderful thing. We're trying to prevent attacks. But it doesn't mean, therefore, there's nothing wrong. Remember how I said there's two ways you can get worse in MS? You can have an attack and not recover, relapse-associated worsening. The other way is from progression independent from relapse activity. Doctors are better at identifying inflammation and treating it than they're at identifying smoldering MS in Pura and treating it. And we need you to help us so that we know that it's going on. Great question.
When you talk about exercise, typically you have cardio and strength, a lot of variations that anybody can do in each. But a lot of us only have so many spoons for a day. What type of ratio, or is one more important than the other for someone with MS?
That's like an A+ level question. So let's deconstruct the question. Many of us remember the glory days of high school, like we were talking about earlier, right? Where if you could run a mile, you could run 2 miles. And if your friend can run 2 miles, you can run 4 miles, right? We're not that way anymore, just because we're adults, right? And I think we need to answer that question two ways. We need to talk about how do you know you've done too much? And then what should you be doing? Because I heard both questions. So here's the metrics that I use for you overdid it. If you're not having a normal evening 3 hours after you work out, that was too much. If you work out and immediately afterwards it's hard to get up the stairs, I'm okay with that. But if 3 hours later you still can't go up the stairs, you overdid it. That's a good, and it doesn't matter how much you did. Even if you only did 5 minutes and then you can't go up the stairs 3 hours later, that was too much. You got to do 4 minutes. Right? We're not having a race. We're just trying to exercise. The second thing is, if the next day is not a normal day, like if the day after your exercise is not a normal day, you overdid it. So those are the two rules that I use. And you got to be really honest with yourself. So, well, you know, doc, I played football in college. I said, I understand that, but you're 54 years old, sir. You know, and you have MS. I mean, so we can't use what you did on the combine now, right? Now, the second thing is that I heard was like, what kind of exercise? And there's 4 aspects to MS exercise that we want to consider. There's 4 aspects, and we don't normally do all 4 at the same time. One of them is cardiovascular endurance. One of them is limb flexibility. One of them is balance, and one of them is core strength. Those are the 4 things. And very few activities, like except for like jujitsu and like probably like gymnastics, do all 4 at the same time. And that's okay. There's nothing wrong with that. I just want you to identify which one you're doing. And you can sort of, if you identify today's a day I'm working on balance, except I'm really having a really bad day working on balance, you might do it seated with both feet flat. You can adjust what you do. And if you're like, well, Aaron, how do I figure out how to do that? You ask your doc to send you to a neurophysical therapist and they'll teach you. They'll say, I want to work on my balance, but it's real. Don't ask me to do this kind of stuff. I'm going to fall over. Okay, well, we'll come up with a way that'll work for you. Great question. Thank you.
Can you tell us about the next genre of medications that you all feel are going to be soon approved?
So 2019, 2020, I first heard about BTK inhibitors. And I came home and I told my ex-wife that I learned about BTK inhibitors. And she said, oh, bind, torture, kill? I said, what? She goes, oh, yeah, BTK, bind, torture. So apparently there was a serial killer in the United States. Very scary stuff. I have zero interest in. So I'm not talking about binding, torturing, and killing when I say BTK. I'm talking about protein tyrosine kinase inhibition. It's a medicine, all right? BTK is protein tyrosine kinase inhibitor, and there's no quiz. I'm not going to ask you to repeat that. These are Scrabble words. They're weird doctor words. But BTK inhibitors are pills which have been invented to treat cancer. certain types of cancers. And we're testing them in MS, and they are very promising. And they're very promising, particularly in maybe treating progression, smoldering stuff, Pira. So we're very, very excited about that. The way they work is cool. Let's talk about it for 10 seconds, which means 3 minutes. So some of the most effective drugs that exist to treat MS today that are FDA approved kill B cells. T cells attack you. They attack your brain. But the T cell can't do it without the B cells stimulating them, which reminds me of high school. So if two men are walking through the high school and bump into each other, there's only one way to settle that dispute in central Ohio in the 90s. You meet behind B building and kick the shit out of each other while everyone watches, right? That's how you settle disputes in Columbus, Ohio, or at least that's what I saw. So I used to attend some of these social events, and there would be two pugilists, and what I noticed was they were always accompanied by 8 of their very closest friends. Their friends were there. Go ahead, man, whoop his ass. I got you. I'll hold your book back. I'll look out for the teacher. If he hits you, I'll hit him. All right, let's go. And they get the kid all fired up. What would happen if one kid showed up at 3:30 behind B building and his friends didn't show up? He's not going to fight you. You know what? Never mind. Bye. We kill all the friends. When we give a B cell, we kill all the friends. The T cell has no friends. The T cell can enter your brain and see your brain and want to attack it. It can't get pissed off enough because there's no friends there. Why do we give some of the medicines routinely? Because when you start to make new friends, we kill those too. That's a very, very effective way of treating MS, it turns out. But it increases risk for infection because you need B cells. And it doesn't do as good as we need to do with some of the aspects of the disease, like the smoldering disease. So we need to do better. So there's a next generation coming out, the bind, torture, kill drug. I'm joking. BTK inhibitors. And we've been testing them. And at the Boster Center, we've been testing many, many of these drugs. And where it looks like they're first going to be FDA approved is in non-relapsing secondary progressive MS, meaning people that used to have attacks, but they haven't in quite some time, and they're getting worse. And we now think that we have a drug, tolobrutinib, that'll work to treat that disease. And that's very, very exciting. 10 patients at the Boster Center from Central Columbus, Ohio, participated in that trial. I'm very, very proud that I got to participate in that trial called the Hercules trial. And what we found was, compared to taking a dummy drug, we could slow down progression in those people by 30%, which we've never been able to do in the universe. That's really a big deal. And so it was fast-tracked at the FDA. The FDA thought that was so amazing, because it's amazing, that they fast-tracked it. And they're supposed to give us an answer next week.
Yes.
Now, some of you have heard that the government took a break. So because they were taking a vacation, we may not get the answer because they may push it out. But we're supposed to hear next week. And if we don't, we imagine that we're going to hear in the first quarter of next year. And I think we're going to have the very first drug that's FDA approved to slow down progressive MS in non-relapsing state.
Why is MS now being considered one disease, regardless on the type of MS you have?
Because we're finally waking up and becoming smart. So you've heard of an autoimmune disease called diabetes. So diabetes is a problem where you have trouble controlling your blood sugars. And you can have 2 people with diabetes, and one of them can go blind from diabetes, where the diabetes takes out their vision. Someone else with diabetes, same diabetes, can see beautifully, but they're on hemodialysis because they lost their kidneys. Same diabetes. One diabetes can cause kidney failure in one patient with diabetes and blindness in another patient with diabetes, same disease, diabetes. We have historically described MS by phenotype, by the outward appearance, which is dumb. When you describe something by the outward appearance, you can make errors in judgment. Oh man, look at that buxom blonde. Shame on me. I just made 2 outward observations of about a hypothetical person, buxom and blonde. It doesn't tell me anything about that human being. I don't know their politics. I don't know what kind of music they listen to. I don't know what they like doing in their free time. I just know 2 outward things about them that don't tell me very much about them. And that's how I feel about the way that we used to talk about MS. You have primary progressive disease, sir. You have relapsing remitting disease, madam. Those are 2 different presentations of the same biologic condition, multiple sclerosis. And we just updated the diagnostic criteria, the stuff that we use to diagnose you, and we did something revolutionary. We admitted that it's one disease. Because now Whether you present with attacks and go on to be diagnosed with MS, or if you present with progression and you go on to be diagnosed with MS, same criteria, because it's the same thing. That's a big deal because it's honest.
Great.
Great. So is steady immune modulation easier on our bodies than the ups and downs of DMTs that knock down the immune system drastically?
Excellent question. Let's deconstruct it. Disease-modifying therapies do different things, right? Some of them kill the immune system, like they suppress the immune system chronically. So we call that chronic immunosuppression. Those are actually some of our most effective drugs. We have other drugs, they don't suppress the immune system, they just tweak it. They modulate the immune system. And then we have other drugs that reboot the immune system. They reset the immune system. And there's upsides and downsides to all of them. Let me give you an example. I have patients that are at high risk for infections, and putting them on an immunosuppressant might be unsafe for them. But we can treat their MS by using an immunomodulatory drug. Let me give you a different example. This will shock some of you, but 20-year-old boys don't always like to do stuff like take medicines. Right? I remember I used to be one. And having a 20-year-old boy take 2 pills a day, in some cases, is setting him up for failure because it's going to be real hard for him to do that. That's not really fair. So taking a pill once a day for 5 days, and then a month later take a pill for 5 days, and then not do anything for a full year, that he can do because my nurse will call and remind him. My point here, sir, is we're going to try to match the need with the efficacy, the tolerability, and the lifestyle to try to pick that drug for that person. And you said there's ups and downs. Certain drugs, there can be ups and downs, not for every patient. I'll give you another example. Some patients, when they take the B-cell depleters that are infused twice a year, the month leading up to their infusion, they feel crappy. And some patients in Wisconsin named that the crap gap, which is now what all of us call it. Most patients don't actually have that. The vast majority do not. Some do. And for those that do, some of them, it's abominable, and we have to take them off their medicine. Others, we can give them some lotions and potions, and some they have it, but it doesn't bug them too much. So that's just an example where in the real world, we have to consider how's it going for that human being and then adjust accordingly. And I don't think there's any like set rule, but those are just some guidelines that I wanted to share.
Thanks. Before I get to the next in-person question, the one online was, are any of the highly effective medications causing cancer?
Yes. Yeah. So if a doctor tells you that a drug doesn't have a side effect, leave. Like they're lying, because all drugs have side effects. Water has side effects. If you drink too much water, you can hurt yourself. So some of the drugs can increase the risk of cancer. Now, does that mean that you should never take those drugs? It depends. There's a risk benefit to everything. Here's the thing I really, really want you to try to do with me. You have to place the risk benefit of the medicine in the context of the risk of the untreated disease. So here's the thing. I'm much more scared of your disease slipping because I can't give you that back than I am of monitoring for cancer. I'm not making light of cancer. Cancer is terrible. But I can monitor and I can treat cancer. I can cure cancer in some cases. And so we have to put the risk benefit of the drug, which is real, inside the risk of the disease. And sometimes we can lose sight. I'll give you an example. There's a medicine which is really effective called natalizumab. There's 2 versions. There's Tysabri and Teruco. Those are infused drugs. They're given once a month in the vein. Very, very, very effective drugs. In some patients, there's a risk of a brain infection called PML. And that risk is between 1,000th of a percent and 1%. Do you know what 1,000th of a percent is? You take $1 and turn it into 100 pennies, take 1 penny and cut it into 1,000 slivers. 1 sliver is your risk of PML if I give you Tysabri. So I don't feel like it's my right to inform you if that's okay with you. Like, I don't really think that's my right. I think it's my ethical and medical obligation to make sure you understand what 1,000th of a percent is, and then I need to shut up and you tell me how you feel. I have some patients that the sheer fact that PML is a possibility, even though they're not at risk for it, they don't want to take that drug. And I don't try to talk them into it. That's not my goal. I have other patients, I take care of a gal, happens to be a retired doctor, pretty smart gal, and she's on Tysabri, and she's a high JC virus antibody positive titer. She's been on it for 10 years. And she says, honey, she calls me honey, when the risk is 1 in 10, call me. And you can't tell me she doesn't understand her risk. She got a medical degree. She practiced 30 years. She understands the risk. She chooses to take that risk. So, thank you for the question.
Spinoff. For those that are on Tysabri for greater than 25 years, has that risk decreased?
So when you take Tysabri, there's a risk that you can get that PML infection. And so there's things that we do to monitor that. There's really 3 things that we're aware of that could change that risk. One of them is prior chemo. So if you've ever had any form of chemotherapy, whether that be oral chemotherapy or IV, even chemotherapy for MS, that can increase the risk of PML if you're given Tysabri. So that's one factor that we have to think about. Does that mean you're not allowed to have Tysabri? Well, not in my shop. It just means we have to talk about that risk. The second thing is we have to check to see if you've been exposed to the virus that causes PML. Because if you've never been exposed to the virus, you can't get the condition. It's like saying if you never come in contact with HIV-tainted fluid, you can't get AIDS. Well, if you don't have the JC virus in your body, you can't get the infection from it. So we can check that. There's a blood test called the JC virus antibody. And if it's negative, nuh-uh. The third thing is time on drug. And so the thought is the longer you're on drug, the higher chance you have for the JC virus to mutate. I'll be very honest with you, I'm not aware of data going out 25 years, Stu, so I don't know out there if the risk goes down. I suspect that it would look like it goes down because you're self-selecting for people that are staying on drug and responding really well, but that's just conjecture.
We were all wrong. It hasn't been out for 25 years yet. So 15 was the number I was supposed to tell you.
Yeah. No, I understand your point, though. 2004, the drug first came out.
Yes, I have asked you for a suggestion. My leg gets stiff, and especially when I get in the crowd and I use a walker and look like I have drop feet. So is there any suggestion you can give me?
100%, yeah. So she shares that she has a hitch in her giddy up, right? And in specific, her leg don't bend too much, okay? So that's spasticity. Spasticity is very common in MS. 70% of people with MS have spasticity like you do in your leg. Spasticity is a situation where opposing muscle groups are not playing nicely in the sandbox. And to explain this to you, I'm going to have to pull out my massive arm. So women, stay seated. All right, so see that massive bicep? You see it? Well, no, you can't really see it. It's kind of hit. So if I want to bring my hand to touch my head, I have to contract my massive bicep. This muscle has to get shorter to bring my arm forward. This muscle back here, my massive tricep, it has to relax because the job is to do that. And I don't want to do that. I want to do this. I don't tell my tricep to knock it off. My spinal cord turns it off for me so that I can do this or I can do this. When you have MS, which is damage to brain or spinal cord, sometimes when you want to do this, that muscle didn't get the email. It was not informed that that was the goal, and it's still trying to do that. So now you have muscles going this way and muscles going that way in the same limb, and you're having a tug of war with yourself. That's spasticity, which manifests in one of 3 ways. Way number 1 is a spasm. Right? There's a spasm. That's a manifestation of spasticity. Number 2 is a cramp, like a Charlie horse will drop a man, right? Where the muscle belly tightens up and you wake up screaming. The third is a limb that's hard to bend. Now, spasticity is always worse under 2 conditions. Well, 3. Let's do 3 conditions. Number 1, any infection. Oftentimes, I'll identify a urinary tract infection or a toenail infection or a respiratory infection because my patient's more spastic. That's a tip-off that something ain't right at the Circle K. So we want to make sure there isn't an infection. Number 2, when you are still, like not moving. So waking up, typically you haven't been moving all night or not very much, you wake up like Tin Man. Sitting in the car for 2 hours, driving to your doctor's office, you can get out and you're a tin woman, you can't move. Because the longer you sit, the stiffer you get. The third condition is when it's cold outside. So waking up in Ohio in February, you're going to be stiff. All right, so what are some things that we can do? Number 1 through 10. 3, he says. He's like, I don't want to stay here all day. I have other things I need to do, Aaron. Yeah, Smart. So number one is hydration. I know that sounds weird, but being dehydrated worsens spasticity. So that's actually, I mean, try it. Like drink more water and you'll be like, that little balding guy was kind of right. The second thing is stretch. Stretching helps spasticity for about 2 to 3 hours. So I like my patients, particularly in the winter, to stretch when they wake up in the morning, before they get in bed at night, and once in the middle of their day. Because that's free and it'll help for hours. And the secrets to stretching are as follows. Number one, you have to hold the position for 30 seconds for your muscles to figure out what you're trying to do. So like doing like this, like that's not stretching adequately, right? You need to hold the position for 30 seconds, do a couple sets. And the second thing is you got to stretch the right muscles. And you may not know what the right muscles are. Who does? Your neurophysical therapist. But oftentimes it's the stuff in the back, like the tush, the back of the leg, the calf. Most of the things that spasm in my patients are behind them. We want to stretch that stuff out. So those are things that can help. We said 3, so I want to do one more. Magnesium. Magnesium is an over-the-counter mineral, and I'm not telling you to take magnesium because I'm not your doctor, blah, 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 blah. But magnesium, about 400 twice a day, helps a lot of my patients with spasticity. Side effect, diarrhea. So some people can take magnesium, and that's adequate with some stretching and some hydration, and they're good in the hood. Thank you for the question.
When you were talking about GLP-1s, it sounded like the goal was autophagy. If that's a correct understanding, what's your feeling about non-drug ways of reaching autophagy, like fasting? What's your opinion?
I'm a big fan. Now, this is theoretical off-the-reservation conversation you and I are having, right? Because this is not stuff that we've clarified, but there's some... So there's a style of eating called intermittent fasting that I'm a big fan of. Like personally, that's how I keep my weight off, like me personally. And it's safe in MS. So intermittent fasting is simply where you eat for a certain number of hours and then you don't eat for a certain number of hours, right? That's all that is. It's timed eating. And one of the major world religions has a very, very important month called Ramadan, where they don't eat when it's light outside. And so for thousands of years, groups of Muslims have been doing intermittent fasting for a month, including Muslims that have MS. And we've studied that, and it's safe, which I like knowing. There's theories about autophagy helping. And I don't know if that's true, but I think it might be. But I want to share a story of a young man that I take care of, right? This young man has really, really bad MS. He can't move his arms or his legs very well. He can move one arm a little, but not enough to use his wheelchair. So he's pretty disabled, and he's a young man. And he gained a lot of weight, not on purpose. He can't move, and it was so he wasn't able to lose a lot of weight. And I taught him about intermittent fast, and he lost 45 pounds. And his bed sore healed up. And his wife cried. She was so happy because they couldn't fix it. And so I think that's really special. I don't know if intermittent fasting autophagy will help, but I think it could.
Thank you.
Your primary care doctor does blood tests, and say you're 20 years old and that cholesterol level that's running great, and it's okay. But then when you're 60 years old, it's not so great, but they're going to say, at your age, you're fine. Why do they not want to keep you at 20 years old? Why are we not adjusting to give you the best life there and keep your metabolism?
So that is a very interesting comment. And it's a little bit outside of MS directly, but let's talk about it just because I think it's very relevant. So specifically, when the cardiologist or the primary care is giving you a cholesterol agent, it's to lower your cholesterol to decrease your risk of heart attack to make you live longer. And it's true that at a certain age, that doesn't matter. The math doesn't math. It's not my field, right? But I have seen cardiologists say, Boster, you don't need to put them on that because it won't extend their life. The thing that we intended to do won't do that. That's a little weird feeling, but I've heard them say that. There's other reasons why we might want to treat cholesterol, however, in MS, right? So for example, anything that can hurt the brain's integrity can speed up your progression of disability. And having a high cholesterol can increase atherosclerosis in your brain and make your blood vessels run harder and make the blood vessels get stiff and make your brain get smaller faster and ultimately contribute to you not doing as well. So I think there's other reasons why we might want to do that. But I understand your question, sir. Thank you for asking.
Have you had experience with having spasticity in either the back or the neck versus arms and legs?
Yes. Was there a follow-up? Yeah, so people with MS have spasticity all over the place. Some people, it's just the leg. Some people, it's like the whole body. Some people, it's half. Some people, it's in their core and they can't bend. Absolutely. And I've seen all of those things.
The question is, I'm 47 years old. I lost the question. And I'm trying to track the imaging going on. Are we using the right imaging to track progress in the brain? Or would there be benefits in functional MRI scans?
Great question. Remember how I said once a year I want to get a picture of your noggin? I was saying I want to look at structure. I want to make sure you don't have any structural damage. So we did that with an MRI. And MRIs, current MRIs, like the ones that you get when your doctor sends you to the scanner, not weird research ones, but like standard ones, look at structure. So they're looking at, is there new damage or not? They don't tell us about function. So if I take a picture of the outside of your house, I don't know if you're eating dinner. All I know is there's 2 windows and they seem to be intact. The door is closed. There's a roof on the house. Siding is white. Like, I don't know about the function in the house. I just know about the structure. That's very important to understand structure, but it's not all of everything there is to know about MS. And there's lots of disease activity, which is absolutely going on that we don't see on that MRI. Remember earlier when I said you can both celebrate that the scan is stable and recognize that you're getting worse? Both are true. Why? Because the pathology that's driving getting worse is not picked up on that scan. Would functional imaging help? fMRI? No, actually, that would not help. There's a type of MRI called fMRI, functional MRI, and it wouldn't help with this. What would help are different MRIs that look specifically at immune function, or maybe like PET scans, things like that. So I think that we're going to see things evolve. I do want to share an update to the MRI, which is amazing. And it was just updated this past year. When you get an MRI and you see a white spot, I was trained to look at the shape and the size and the location to decide if I thought it looked like MS. We now have MRI sequences that can tell us with some degree of authority that it is or isn't MS. Not 100%, but if we see something called the central vein sign inside the white spot, or if we see something called the paramagnetic rim or pearl, it's very likely that's a demyelinating lesion. And so we're getting smarter at being able to clarify what we're looking at, which I think is really, really great.
Thank you. The last online question is about stem cell. Can you tell us why they shouldn't be stopping in at places that are all over the map?
So show of hands if you've heard of stem cell therapy. So many of you have heard of stem cell therapy. So stem cell therapy is not a drug, it's a procedure. Did you know that? It's not a medicine, it's a procedure. So here's how the procedure works. First, we take out your stem cells. Like, we give you medicines and you make a bunch of stem cells and we put them on ice. Then we kill you. Then we give you lethal doses of chemotherapy, which ablate your immune system, which is ablate is a doctor word for kill. So we remove your immune system permanently. So now you're like John Travolta, boy in the bubble. And if you get a cold, you'll die. But it treats your MS amazingly because the immune system was the thing that was naughty. So we just killed the naughty thing. But now you're going to die. So before you die, we give you back your stem cells and pray they take. The thing I want you to understand is the stem cells don't make your MS better. They prevent you from dying. The thing that makes your MS better is killing the immune system. Now, stem cell transplantation has been studied in MS for many, many years, like long before I started in the field. And it's getting increasingly safer and safer and safer. It used to have mortalities. We don't really have very many mortalities anymore, thank goodness. But it's still a very, very aggressive therapy. In some countries, like in Great Britain, it's approved for use under certain circumstances when people have really bad MS. It's not approved in the United States. So if an American patient wants to have a stem cell transplant, the ethical option is to go to a clinical trial that's studying stem cell transplants so we can figure it out. There are a major problem called stem cell tourism. Stem cell tourism is a major issue, and the American FDA is trying to shut it down. But you can fly to exotic locations like Russia or India or Chicago and have them swap out your bone marrow. And I don't recommend that you do that just yet. It's not prime time. And so The problem is if they really do a proper stem cell transplant, that immunosuppresses you and you're at risk. In a lot of those places, they do their thing and then they send you home with nothing. And the other thing is that oftentimes it's not a real stem cell transplant, which is safe, but you just spent $100,000 on a sham quack procedure, and I don't want you to do that.
A lot of studies have been done looking at remyelination, and they've been successful in animal models, but when they've gone to clinical human studies, they've failed. So the question is, one is, for your study, have you done an animal model? And secondly, are new animal models being developed?
So the gentleman's saying, you know, we test drugs and we don't start test them in humans. We start test them in models of humans. Like, so we'll test them like in mice. We can cure MS in mice. Did you know that? But I don't treat mice. Like, I treat humans. But we use mice to test the ideas, and then if we think it might work, then we move into humans. And so there are remyelination trials in mice. Absolutely. Is the trial that I'm looking at for remyelination, did it have animal data? I'll be very honest, I don't know. I'm partnering with a group that's doing it. They did similar research in a different autoimmune disease, and they had some success. And so that was our impetus to pivot. But the trial that I described to you is a pilot trial. And so when you talk about the way clinical trials are done, this is really, really an early proof of concept. That's a great question. Animal models. There's a bunch of animal models for MS which we can use to test remyelination. Like there's all kinds of different EAE models. Yes.
You were saying about problems like waist down.
Yep, the down there's.
Yeah, the down there's.
Yep.
Can you elaborate on that a little bit?
Yeah, absolutely. So bowel, bladder, and bedroom function is housed in your spinal cord, amongst other places in the nervous system. So when someone has damage to the spinal cord from MS, it can interrupt bowel, bladder, or bedroom. The most common bladder problem that I see is called overactive bladder, which manifests as, oh my God, move. I'm going to pee whether you move or not. And we see an overactive bladder getting up at night to go to the bathroom all the time. That's called nocturia, where people are getting up multiple times a night and they're not getting restorative sleep. Right? We can see frequency, where you're going to the bathroom 84 times more than all your girlfriends. Right? So that's a problem that we can see very commonly. The good news is it's actually pretty easy to treat. We can typically treat it by some changing when you pee, like timing your voids, and taking 1 pill a day. There's another problem you can have in MS with the bladder, which is where you can't empty, where you can't get the urine out. And you strain and you push and you stand up, you gotta sit back down. And then every once in a while, you'll just lose your water, right? And that's called urinary retention. And there's different medicines for that and different treatment for that. And then sometimes nature's too generous and you can actually have both. And then we have to treat both, right? We already talked about bowel. When we talk about bedroom, a lot of times people only talk about one of the two genders, right? And there's lots of things that we can do to help women in the bedroom with lubrication, achieving orgasm. Do you know there's a pill for low women libido called Addy? It's an FDA-approved pill you can take. That's a real pill. It's FDA-approved. Think about that.
So I'm on Ocrevus, and my question is, I know it depletes my B cells. I have 0. I saw the blood work, but my T cells have increased. What does that do with my immunity going out in public, wearing masks and things?
That's a great question. And that's really a very relevant question when you're taking an immunosuppressant medicine to treat MS. I love me some Ocrevus. I think these B-cell medicines are highly, highly effective. And I hope that it's working really well for you. So she says, I look at my numbers and my B cells are low, and that's proof that the drug's working. Yay. But my T cells are high. That's normal when you take Ocrevus, and that doesn't make the drug work less. Because even though you have more T cells, they can't attack you without their friends, the B cells, to piss them off. So that part's okay. Having elevated T cells doesn't increase risk of infection. It decreases your risk for infection to some degree. So I don't look at those numbers and say, like that's a concern. The things that I look at when I'm giving someone a B-cell depleter, I check labs twice a year. I look at their B-cell number, that's called the CD19, and I want it to be 0 because I don't want them to have B cells for the reasons we talked about. The second thing I look at is a lab called the ALC, or absolute lymphocyte count, which is all the B and all the T cells. And so I want that number to be above 600 because if it's below 600, I'm suppressing them too much and you're at increased risk for infection. And the last thing I check is the IgG. That's doctor talk for antibodies, particularly memory antibodies. And I want that to be above 600, again, so that you have enough to fight off bad guys. So when we check those, if they're low, we may hold your infusion a little bit to give you time to build those back up. We may not, depending on the situation. Great questions. Thank you.
My thanks to everybody, okay? My thanks to my buddy. And we're going to call it a wrap.